thank you all for being here. Fair warning, I think this is. I'm coming at you from my shared office, as many of us are I'm still living that sort of pandemic life, remote working thing, which I've occupied for 18 months. And this morning, as I was sat here in another workshop, I happened to look down and there was a large mouse or small rat looking at me quite surprised down by my feet and then scuttled off. And I was a little bit shocked. I don't know why it was surprised because I was not being quiet. It, however, was being very quiet as a mouse, you might say. So if you suddenly, I don't mind mice/rats. I'm not opposed to sharing my space, but it was a bit of a shock. So if you suddenly see me jump and disappear, that's what I'm dealing with. A little bit later, just to add to my wildlife excitement, there was I say large spider. You've got to realize when I say large spider, that's other people's definition of small to medium, but kind of hanging out above here. That if that does happen, I am out of here because I am not comfortable with the old spider. So
if you run off screen, that's what happened.
If I run off screaming, it's most likely the spider. If I'm like, oh, cute, it's probably the rat/mouse. Okay. I mean, these are the trials and tribulations that we have to go through to bring you hopefully fantastic presentations on how to connect with communities. But I thought you needed that context. All right, enough about me and my wildlife adventures for today. So we're going to have this really, what I think is a really important element of what we talk about, which is this outreach piece and component of coordinated specialty care. Kate Hardy, I know many of you, so that is fantastic. For those of you who don't know me, I'm a clinical professor at Stanford. I'm the site lead for the Stanford site for the TTA, which is UCSF, Stanford, and UC Davis. And I have been doing this early psychosis gig for a long time at this point. And back when I was more involved at the community level and was working with Felton, going out and doing outreach presentations was one of my absolute favorite things to do. Really loved it. So that's why I'm here to talk about that. Jess, do you want me to say anything about this particularly? Do you want to say anything, or is it just to remind people where we are on the map?
Yeah, sort of just to remind people where we are. I know that sometimes a lot of the feedback that we've received is that this is very complicated, and it is a lot of different agencies, and the flow of those agencies is very complicated. So I'm just trying to plaster this image wherever I can to hopefully provide some clarity about the nature of our program and what we do. So as you can see, EPTTA right there under EPI-CAL, that's us for the Training and Technical Assistance Center. And underneath that is EPI+, that's the grant that we talk about so often. So most of you here are probably EPI+ grantees. If you're not, that's also okay. Welcome. You'll probably find yourself somewhere on this chart as well. Put a little "you are here" star just to sort of illustrate this. And if you want to look at this more in detail, it's also in Canvas. It's called our welcome packet. And that's a little bit more about what we do right there. That's pretty much all I'll say.
Thank you. Definitely did that more eloquently than I could have. So, learning objectives. By the end of this, you will know why we conduct outreach if you do not already know that, which I suspect many of you do. We'll have thought through potential forums for outreach and identify key stakeholders in the community for targeted outreach efforts. And spoiler alert, Felton, I've used one of your maps as an example because it's a lovely example of what this looks like. So, why is this so important? Well, there's this huge shift, this huge mental shift that many of us need to make, and certainly many providers need to make in the community, where oftentimes around mental health care, we're putting up barriers, right? We're saying, well, we have so many referrals, we have such a long wait list that you're going to have to jump through all these hoops before you can see us. And then you can sit on a wait list for a long time. But if you go somewhere else, that's fine. Actually, that'd be even better, right? That's certainly, to some extent, the department I operate in. We have a huge wait list within psychosocial treatment. And that's like just these barriers. And we can put you somewhere else because we just can't see you. That is not what we do in early psychosis care. In fact, it's complete opposite. We are actively and assertively going out into the community, looking for appropriate individuals for the coordinated specialty care service. So there's a big shift in perhaps how we think about that. It's less of a wait and come to us and more of a go out there and find, identify, and help support access. And a lot of this was kind of really described and sort of held together in what's called the Early Psychosis Declaration. It's a little bit older now, it's from 2005, but it was the IEPA, what do they call themselves now? Intervening Early in Mental Health, IEPA. The abbreviation doesn't align with the title. I don't know why it was changed. Plus the World Health Organization, the Bertolozzi author that, pulling together what are these core components internationally of what early psychosis care should look like. And in many ways, what we offer in coordinated specialty care maps really beautifully onto this international piece. And a large piece of this is that little spoke you see off to the side there in green, which is raising community awareness. And so out of the Early Psychosis Declaration, that looks like regular outreach to all stakeholders, mental health workers, educators, inpatient services, families, youth, community groups, and beyond. And it can take many different forms, and we'll talk about these different formats in a little bit. It could be formal outreach, informal drop-in, social media, getting very creative about this. We'll think a little bit about that in a second, but just lots of different ways for us to proactively go into the community, provide messaging around early psychosis care, around what is available, and hopefully aligning the two. So, of course, we got to tell you some of the research. It's what we live by, right? So what does the research tell us about outreach? Well, again, a rather old study, but seminal because it really did help pave the way for thinking about this proactive outreach piece, was the TIPS study from Norway. And this was a really large scale information campaign. Particularly targeted in many different forums, but the one that always comes to mind was within sort of cinema and movie theaters. There would be informational, like infomercial trailers before the main show. It sounds very old school, providing information on what early psychosis looks like and how to get care. And what they found was during the information campaign, the duration of untreated psychosis that we know to be so integral and important to outcomes reduced from 16 weeks to 5 weeks. Now let's just pause for a second, kind of sidebar. In this country, we'd be quite happy if we could get it to 16 weeks, because at last count, it was 26 weeks on average. No, it wasn't 26 weeks, I'm sorry, it was longer than that, it was 72 weeks, about 18 months. So if we could get it to 16 weeks, we'd be happy. But in Norway, they were saying, well, 16 weeks is too long, we want it shorter. So during the information campaigns, they saw this reduction from 16 weeks to 5 weeks. When the campaign was terminated, and it was kind of this naturalistic study, funding ran out, as it often does, so they couldn't keep sort of providing the same information, but they kept monitoring and collecting data. They found that the duration of untreated psychosis returned to 15 weeks. So they were really sort of from that promoting this need for ongoing, right? We can't just provide this message once and be done with it, but this ongoing education. And as a consequence, seeing improvements in the duration of untreated psychosis. More recently, Michael Birnbaum over on the East Coast in New York, along with others, did this study using Google AdWords to try to reach prospective patients with early psychosis. And so this was really linked to search terms that people put in, like hearing voices, psychosis, seeing things. And then that would link to screening. And then the screening, if screen positive, would link to early treatment programs, primarily coordinated specialty care. What they found was that the ads for anything related to psychosis was clicked on 4,350 times. 44% of that led to obtaining specific information. 15% of the specific information led to a completed screener, but only 1% of people who completed the screener went on to early treatment programs. And of that, nobody actually enrolled in an early treatment program. So although they had this big, large scale, very tech-driven outreach, it didn't actually result in any referrals to early psychosis programs, unfortunately. But what's interesting is, or what's harder to measure here, is the impact of that education more broadly, right? There's a number of people there, of the 4,350 people clicking on the ad, assuming it wasn't just one person repeatedly clicking 4,000 times, but let's assume 4,350 unique people 44% of those learned, hopefully, new information about psychosis. But that is much, much harder to measure the impact of. So we know it didn't translate to referrals necessarily in contact services, but we don't know what it looked like further upstream. What does the research tell us about where we should target? Well, one of the things is that, again, fairly recent paper by Radigan et al. Looked at early psychosis programs and where the majority of referrals came from. And the majority come from these acute behavioral health centers or inpatient settings. And so that really tells us that targeted outreach to these sites is really essential. So our inpatient centers should know that early psychosis programs exist and how to connect to them. Places, partial hospitalization, acute settings should likewise know, and again, how to refer and how to connect. So these are really key stakeholders for us. A study that I did a couple of years ago and published in 2020, and I see I did anything in 2020, it always amazes me because the whole year seems like a total blur, but apparently I published a paper, so that there we go. But this was reaching out to a number of individuals. Well, we did a survey that was developed in collaboration with individuals with lived experience of psychosis as part of our lived experience work group through PEPNet. And the lived experience work group identified that they'd be really interested to know, how do people access care and what are some of the barriers of accessing care? So with the work group, we developed this survey, we pushed it out across a number of places, got pretty good response. I'm blanking on the actual number, but I remember being very pleased with it, and found that people generally reached out to a number of different sources before accessing care, primarily physicians or a clinic. So physicians being primary care providers, emergency room, NAMI, or doing online research. So sort of taking what we see from Radigan of like the ER, the acute settings being really important, but also expanding and realizing that there are other sites that are also really important that should know about what is available locally and how to make that connection. What's also interesting from that is we surveyed, and as we surveyed, we asked, are you the individual with lived experience of psychosis or are you a caregiver? And we found by looking at those results sort of differentially that youth generally preferred social media as a means of receiving information, whereas families preferred websites and brochures. So it's a long time since I've had a brochure, but I've got to admit, as a family member, I would probably prefer to have something in hand that I could take away with me rather than having to try and turn to TikTok and figure something out. Whereas youth who are more digital natives might prefer to receive this information in a digestible form that fits for them culturally. So again, we have to be thinking about who are we targeting, what are we targeting, and how is it being delivered for these different and distinct groups. And importantly within that, we really need to think about how do we reach out to different cultural groups as well. So a study by Coleman talked about how Asian patients and non-Hispanic Black patients were less likely to have had a visit with specialty mental health care prior to the first presentation of psychosis. So if we just took Radigan at face value and said, well, let's do all our targeted outreach here, we'd be potentially missing a huge portion of the population, and that'd be terrible. So what Coleman recommends is the importance of outreach beyond traditional mental health settings for these groups, including faith-based organizations and homeopathic practitioners as a target for outreach. And then Steve Lopez has done a lot of work in terms of outreach to Spanish-speaking populations. He's based down at UCLA. And so La Clave is if I'm saying that correctly, and I apologize if I'm not, but is an initiative that he's developed to increase literacy of psychosis within the Spanish-speaking population and teaching promotores, again, apologize for my pronunciation, but to increase the psychosis literacy and connection to services. And Dini Alawoye last year highlighted the challenges for Black youth in the United States accessing first episode psychosis treatment, noting that trauma, substance use, and structural barriers delayed access to treatment overall. And that oftentimes trauma included traumatic experiences related to entry into services. So if individuals had traumatic experiences in relation to mental health care, Or you could also imagine having witnessed traumatic experiences in relation to mental health care. So that might be law enforcement getting involved through crisis. Then that would be associated with a longer duration of untreated psychosis, which makes a lot of sense, right? So again, I just want to go back to, if we stay at this level of Radigan, although important, we run the risk of then missing a population that needs a lot of help, but isn't potentially getting access to care in the way that we would really want to. And so this is where we need to think perhaps maybe more creatively about how to outreach to these communities. And these two really nice initiatives are not psychosis focused necessarily, but I think they're worth talking about, both based in Washington, DC. Psychotherapy, which I love the title of, I wish I'd come up with something that cool, was using hair salons as an entry point to mental health treatment through both beauty salons and barbershops, and training individuals who work in those settings to be able to provide resources and connections should somebody come in and be talking about things. And you know, that makes sense, right? Somebody comes in to get their hair done, you're there for a while, running out of what to talk about, you know, you've gone through what you're going to do on your Friday night, and they're saying, well, how's your son doing? Oh, he's not doing so well, he hasn't left his room for a while. Having these individuals who are there, who are trusted members of the community, provide actual resources and referrals, it could be hugely beneficial. And then the barbershop embedded education is sort of a similar initiative where they're training barbers in providing empowerment tools and resources and referrals locally. So again, just putting it out there, not psychosis specific. I don't have data around reduction of DUP from these sorts of initiatives. But as we get into sort of thinking about discussion in a little bit, these might be the things to be thinking about within your communities. Who are the trusted people? Who are the people that we need to train to provide the message for us? Because those individuals are representative of something more trusting and more connected to the community than we might be kind of as a removed entity. Or maybe, you know, you guys already represent that. So how are you going to make those connections and provide that education? So we need to get quite creative. So what's the purpose of this? Well, it's, first of all, it's a bit of a sales campaign, right? You need to tell people about your program if we want clients to get in. So we're telling people it's there, it's open, this is what we offer, this is what you need to do to get in here, promoting and sort of selling it a wee bit. We're providing education about psychosis and the benefits of early intervention. So even if the audience you're talking to never refers somebody to you because, I don't know, they just don't happen to come across anyone, they've got different knowledge than we just talked about, right, to counter all this misinformation that we see in the world about psychosis. So it's so important that we get that message out there in that way. I'm not all that fun to have at parties sometimes because people ask me what I do, and I'll say, and I was at a wedding once and I said that I worked with schizophrenia and psychosis, and this woman went off on this rant about how her cat was schizophrenic, and I was like, nope, that's not what it is. And I made this poor, slightly tipsy woman sit through a very long didactic on what psychosis actually was and why her cat could not indeed be psychotic. So we're getting the information out there always. You can have time off at a wedding, I promise. We're trying to reduce the duration of untreated psychosis. And as you all know now, through many of the trainings that you've been in for coordinated specialty care, this is one of the key things that we're always trying to target. If the duration of untreated psychosis can be as short as possible, the outcomes are better. So we're trying to make that period of time between the onset of psychosis and the initiation of treatment as short as possible to improve long-term outcomes. And as I alluded to, here in the US, slightly old, 2015, but it was 74 weeks DUP. We're awaiting the newest data. Hopefully that's decreased. By comparison, in England, the expected DUP, and this is monitored very carefully, is 2 weeks. So we've got a lot of catch up to do. We're trying to teach staff to identify early psychosis, and importantly then how to talk about it. Because it's not really good enough for them to just go, oh, I think it's that psychosis thing that person came and talked to me about, but I don't know what to do. I don't know what to say. What if I make it worse? And then they just don't say anything. But that they actually then have language to express their concerns to the family, to the young person themselves, and help them connect to the service, so that we're giving them the tools and skills to do that. tackling stigma as part of the education piece, and then promoting hope and recovery, because we don't see that in the media, right? John Smith recovered from psychosis and graduated college doesn't make headline news. It should, but it doesn't. So we're there kind of presenting these optimistic, not even optimistic, realistic recovery-oriented messages. So who are our potential targets for outreach? Here we go. Mental health workers directly, inpatient, outpatient community, educators, school counselors, like we just talked about, youth directly themselves. And we need to get creative about how to do that, because, you know, they're probably not all just sat around waiting for you to come and talk to them. Although if it's part of a health education class, maybe so, and that might be a way of being creative about it. Families directly, and that actually for me was always the harder one, of where do families congregate outside of the churches perhaps. Like, so how do we get to the family directly? And then community groups, that could be faith groups, that could be something else. But these are like our key outreach audiences. And this is an example, this is from Remind, so thank you, San Francisco, of an outreach map that we developed in one of the calls that we had. But this is essentially something that if you're thinking about outreach, I would suggest it doesn't have to look this fancy. If we're together in a physical space right now, I'd probably have a whiteboard and a piece of pen and paper and my messy handwriting. And I'd be saying, right, so what's your program? Who are you trying to outreach to, these key areas that we've just talked about, plus any others I've missed? And then how do we break that down even further? So here, for example, we've got youth. For Felton, this was about doing class presentations directly in schools, pre-COVID health fairs, but could we also direct youth outreach through social media, using TikTok or Instagram, getting really creative around that, particularly if we're not having the same access as we did pre-COVID perhaps. With families, that might be NAMI. Although NAMI is often focused a little bit further in terms of the mental health trajectory, it's often a place that families reach out to. So NAMI should know about the available resources and how to make those connections. And knowing from the research that we did that maybe families prefer that brochure versus something that's online and social. So really thinking about all these different components. Community partners is where we can get really creative and really think about the unique features of your own county and your own community, and where each of these really sort of show up. And how you do outreach to one area is going to be very different to how you maybe outreach to another area. And it's going to require a lot of thought. Part of the work that we're doing with the OAC is really thinking as well about how do we outreach and how do we develop early psychosis services within rural settings. And part of that work is requiring us, in partnership with those rural counties and in partnership with some folks up in Washington State who've done a lot of this already, is what is the messaging around early psychosis care that we might need to shift. So for example, one of the things that we might emphasize in an outreach presentation is that coming in and getting early psychosis care and moving towards recovery helps your child towards independence and being able to go off in the world and do something separate from the family. Well, if in the community, in the community, that's not valued in the same way, because in that community, the value is in the young person staying close to the community and helping the community, that's not going to be a very helpful outreach message. So that would need to be shifted and altered to map with what was valuable to that community. So you see how we kind of think about the messaging is going to have to shift depending on who we're outreaching to. And we can only do that in collaboration with the community partners themselves. Thank you. So outreach formats, we can be all formal and do presentations like this. For some people, this is going to work really well. For others, it is going to turn them off massively. I will say, if you're planning to do outreach presentations, again, many of you already know this, but one message is not enough to keep returning annually, at least, if not more frequently. Staff turnover, retention of information. And when you're going out and doing a formal presentation, planning enough time to discuss cases and being able to follow up on referrals in real time, because there's no time like that immediate moment when the person's like, oh, I have a client just like you described, how do I get them in? And if you've got to be like, oh, I've got to run, you know, there's a chance that's going to sort of fall through the cracks. But if you can do something about that there and then, even better. It might be about regular attendance at county triage meetings, inpatient discharge meetings, being, even if each week you're not getting regular referrals, showing up, being that face that's always there. It's like, oh, is that somebody for me? Can we think about that? It can be really helpful. Informal discussion of services, having an elevator pitch ready for the service. What would you say in just a couple of minutes or less about early psychosis identification and referral into your program? Could be about making sure, depending on COVID and how things are, about having an open house at the program and sort of regular drop in, meet and greet the staff, showing up people around the premises, and then again, destigmatizing what some of this care might look like. And providing community training. People will show up to many a thing with a free lunch or some CEUs if those are available. So providing training within the county on early psychosis identification, assessment, and intervention. Participation in community events like going to Patagonia. I love that. Not actually to Patagonia, although you could do that as well if you wanted, though maybe quite a long way to refer somebody, but the company. Going into mental health awareness events of MHA San Francisco, NAMI across the different counties, and having and developing relationships with them. Developing social media. If you have a web page, please make sure it A, works, and B, is up to date. Absolutely critical. And then keeping up with how do youth engage around social media. I'm told Facebook is just for old people, which is probably why I'm still on it. And TikTok is the place to be, which is probably why I have no idea what a TikTok actually is, but apparently it's a good thing to have. Mailing lists, newsletters, leaflets and flyers, ensuring that they're available in threshold languages and that your translation is checked by a native speaker that's familiar with mental health. So this is when it starts to get quite expensive, but it's absolutely critical. And I would also just share very anecdotally, make sure you check your flyer so carefully for any typos. I was once in a county meeting where we were sharing some promotional information about a program that had just developed, and one of the county personnel asked about a typo, and it turned out that in there it said that the service served recent onset psychos, and the IS had been missed off in the end, and that was incredibly embarrassing and really quite stigmatizing. So be very careful in the checking of any materials you create. But were you to do an outreach presentation, which is still old school, but I encourage us all to be creative beyond this box. This is what we want to include, right? We've just talked about information, differentiating between clinical high risk and first episode, tons of case examples, because this is tough stuff to get if you haven't spent years in school, understanding psychosis, and even then it's hard to get. So we need to make it very, very clear, but also make it clear that it's not for the individual to make that, the referrer to make that distinction. It's up to the clinic to make that distinction as they do the assessment. We can provide optimism and importance of early intervention, introducing the program, referral process, and the telephone number or way of doing the referral. And then, like we said, training staff to talk effectively about psychosis to youth and young and families, emphasizing hope and recovery. And I think all of that could also be TikTokable, perhaps. I don't know. I'm intrigued now. I want to know about that. Who should be providing outreach within your service? Well, different models exist within different counties. I know this. So it could be that there's a single individual responsible for outreach, who's forming these relationships, acting as a single point person for referrals and dedicated to outreach efforts. Or you could be choosing to cross-train all staff in outreach. So all staff know how to provide this messaging. They might be able to draw upon clinical experience to provide more real-world experience. Or maybe we hybridize, So there's different ways, and it really depends on your agency and what's going to fit. It's all TikTokable, yeah. What's going to fit with what you can offer. Kind of, I guess, repeating a little bit of what I've just said, but being creative, I've emphasized that a lot. Making sure that if you're doing these presentations, you've had lots of time to practice, that you've been able to get feedback on that, and then tailoring the presentation for the audience. And then right before we finish up, as ever, again, we love data at the TTA. We would really encourage you to be tracking the outreach that you're doing and where you're outreaching to. So who has been in your audience? Who have you reached? And where did you go to do that? And this is an example of data from EDAPT at UC Davis. And so you could see, I actually forget, this is from Tara, aside from Tara, I forget at what time point current was, but it was over a period of time. And you can see that they did most of their outreach to community mental health settings, and then a smaller amount here in red, community event or presentation. But having this data then helping to perhaps track into which of those then yielded referrals into the service so that you can really target your presentations going forwards.